Okay, so today we're going to talk about management of patients with neurologic trauma and several other subjects, but we'll start with the neurologic trauma. Head injuries. This is a broad classification that includes injuries to the scalp, skull, and brain. Um, this affects about 2.5 million people. Have head injuries every year in the United States. The most common cause of death from trauma is head injury. The most common cause of brain trauma is falls. There are several groups at risk. The highest risk include children, so 2 to 4 years old. And that has to do, you guys just finished up your peds, so you remember their head's a little bigger. Coordination's an issue, so they tend to fall head first. Adolescents, 15 to 19 years old, mostly due to risk-taking factors, and adults, 65 and older. So remember all the changes that happen as we get older, sensory perception issues, that sort of stuff. And the best approach to head injuries is prevention, obviously. So the types of head injuries we're going to talk about are scalp wounds and skull fractures, brain injury, closed brain injury, open brain injury, concussion, contusion, diffuse axonal injury, and intracranial bleeds. So the manifestations of scalp and skull fractures depend on the severity and location of the wound. For scalp wounds, scalp lacerations, they tend to bleed really heavily and are portals for infection. Skull fractures usually have localized persistent pain. Fractures at the base of the skull may have bleeding from the nose or ears. We need to make sure, do the halo test to check for cerebrospinal fluid. Other signs could be battle signs. It's the bruising behind the ears or raccoon eyes, bruising of the bilateral eyes. A basilar skull fracture is a break in the bone at the base of the skull. You may get the battle signs or raccoon eyes from this, or the CSF leak occurs in about 20% of cases and can result in the leaking from the ears and nose. Meningitis is a complication in about 14% of basal skull fractures, and a basal skull fracture occurring in the bones at the base of the skull usually results from force applied to the head, such as falling from a height. With basal skull fractures, as we get into this chapter more, we'll be talking about nutritional support and the potentials of needing an NG tube for stomach decompression or for nutritional purposes. Know that a basal skull fracture is a contraindication for an NG tube, so just keep that in mind as we talk about that moving forward. So there's primary injury and secondary injury to the brain. The primary injury are consequences of the injury. So this happens immediately at the time of the injury, whether that be a skull fracture, subdural hematomas, concussions, diffuse axonal injury. These things happen immediately. Secondary injury develops over the ensuing days and hours after the initial injury. This is caused by edema, ischemia, and chemical changes in the brain associated with trauma, so your acidosis and things like that. And most of our interventions, or a lot of our interventions, will be aimed at eliminating or minimizing this secondary injury. So closed head injury, this is usually blunt force trauma. Acceleration, deceleration injuries occur when the head accelerates and then rapidly decelerates, damaging brain tissue. Sorry, dog's being a jerk. Open brain injury occurs with penetrating into the brain, or trauma is so severe that the scalp and skull are opened. So remember, anytime that you have an open injury, antibiotics, prophylactic antibiotics are indicated because we're concerned with infection. Right? So a contusion, this is or rather concussion. A concussion is a temporary loss of consciousness with no apparent structural damage. A contusion is more severe injury with possible surface hemorrhage. Symptoms and recovery from a contusion depend on the amount of damage done and then the associated edema afterwards. They have longer periods of unconsciousness with more symptoms of neurological deficits and changes in vital signs than you might see in that you would see in a concussion. With major head injuries, now not a simple scalp lock, but with a skull fracture, any skull fracture, open or closed head injury, you want to assume C-spine until it's ruled out. So you'll be in C-spine precautions until you're cleared. Therapy for head and brain injuries is to preserve brain homeostasis and prevent secondary damage. So we talked about that, treating the edema, maintaining cerebral perfusion, maintaining oxygenation, so monitoring the respiratory status and oxygen levels, and managing fluid and electrolyte imbalances. So diffuse axonal injury, this is a brain injury in which scattered lesions in the white matter tracts as well as the gray matter tracts occur over a widespread area. DAI is one of the most common and devastating types of traumatic brain injury and is a major cause of unconsciousness and persistent vegetative state after severe head trauma. The immediate course of action needed in the cases of DAI is to reduce any swelling inside the brain, as it can cause further damage. In select cases, a course of steroids may be given to reduce swelling. This is a devastating injury, right? It occurs when the brain rapidly shifts inside the skull. As the injury occurs, the hallmark sign or symptom of this is immediate coma. And this is very difficult to detect using a CT or MRI. It's usually diagnosed by ruling out other issues. So we'll talk a little bit about the intercerebral bleeding. There you can have an epidural hematoma, a subdural hematoma, which can be either acute or subacute or chronic, and intercerebral hemorrhage and hematoma. This slide just shows you areas where you can have bleeding in the brain. So this is a subdural hematoma, this is an epidural hematoma, and this is your intercerebral bleed. Now, if you look at the picture, it'll kind of give you a clue as to what sort of interventions you can do. Clot evacuation will be much easier in like the subdural hematoma than, say, the intercerebral bleed. So your epidural hematoma, this is a blood collection in the space between the skull and the dura. Patients may have a brief loss of consciousness with a return to consciousness. And then as the hematoma expands and gets bigger and the pressure increases, you will suddenly have a reduced LOC. So the hallmark sign is brief loss of consciousness followed by consciousness that may progress to unconsciousness, right? This is an emergent situation. Treatments include measures to reduce ICP, and we've gone over those extensively in our previous lecture. So make sure that you're studying those and you remember all of those. Clot removal, either through a burr hole or a craniectomy, and of course we want to take measures to stop the bleeding. The patient will need monitoring and support of vital functions and respiratory support. So any of these, remember, the brain is kind of the control center for the rest of the body. So when we have a head injury, we need to make sure that we're also paying attention to other vital functions, because those are all controlled by the brain. And, you know, we go ABC, so always make sure we're taking care of respiratory issues. And again, with the oxygenation, it's important. So subdural hematoma, this is just a collection of the blood between the dura and the brain. Acute or subacute. So acute subdural hematoma will have symptoms develop over 24 to 48 hours. The subacute symptoms develop over 48 hours to 2 weeks. This does require prompt treatment, and they'll probably do a craniectomy and control of ICP. So they'll want to go and do a craniectomy, evacuate the clot, stop the bleeding. Chronic subdural hematomas, these develop over weeks to months. The causative injury may be minor and forgotten, so it may have been just something that didn't seem like a big deal at the time. These signs and symptoms of this can fluctuate. Usually there's some sort of headache, at least at some point during here. And you may have some change in neurologic function as the hematoma gets larger. Treatment, it depends on the severity, if it's stable or unstable. So sometimes they'll you get a subdural hematoma that's small, isn't causing any really neurological symptoms except for potentially maybe a headache, and it's not getting any bigger. That means that it may have tamponaded itself off and the bleeding is stopped, and we'll just monitor it. But if it's causing serious problems, so if the risks outweigh or the benefits outweigh the risks, then they'll go in and do a clot removal. So intracerebral hemorrhage, this is hemorrhage that occurs into the substance of the brain, may be caused by trauma or non-traumatic causes. If it's traumatic cause, some sort of injury, then it's considered a traumatic bleed. Your non-traumatic bleeds are considered a hemorrhagic stroke. And these will be treated the same way. Well, the signs and symptoms will be the same as a stroke. Treatment is largely supportive for these intracerebral hemorrhages, because they may not be able to go in and remove the clot. If they can, so that you can do a craniectomy and to remove the clot and control hemorrhage. But this may not be possible because of the location. If you think back to that picture where you saw the bleed in the center, you would have to damage a lot of tissue to get to the clot and take it out. And some bleeds aren't localized into a clot area you can remove. They may be diffuse and undefined, so they can't be evacuated. So interventions for those are largely supportive, and they include supporting function, whether that be respiratory function or whatever needs to be done, administering of fluids and electrolytes, antihypertensive medications, and we may allow some hypertension, but keep it within the parameters of the orders. Administer fluids and electrolytes and support your patient. So diagnostic evaluations for head injuries and head trauma is a physical and neurological exam. So assessing, wait a minute. So we may do skull and spinal x-rays. So a skull x-ray can show you fractures in the skull, but won't show you bleeding into the brain, right? It won't show you anything inside the skull. Spinal radiograph can be done to clear C-spine, looking for any spinal fractures, and we'll talk about spinal fractures a little bit later. CT scan will be done emergently, may be done emergently, and this can show you the structures inside the brain. It can show you show bleeds, those sort of issues. Be aware that an epidural hematoma uh, may be missed, may be difficult to see on a CT scan and may be missed. So sometimes we'll just do that following. They'll have to do may have to do a lumbar puncture for that one. Could do an MRI or PET scan. CT is the most common emergent test, followed by MRI. So manifestations of brain injury, altered level of consciousness. Remember, we used our Glasgow Coma Scale to assess LOC. Pupillary abnormalities, sudden onset of neurological deficits and neurologic changes in sensory movement or motor. So remember, that's the signs and symptoms of stroke, paralysis, problems with speech, facial droop, sudden difficulty with vision, speaking, understanding words, all of those signs and symptoms. So think back to that, right? You may see changes in vital signs. So when we talk about assessing for intracerebral pressure and changes in vital signs, we're looking for potential changes that may indicate increasing intracerebral pressure. So these include the slowing of the heart rate, right, bradycardia, increasing systolic blood pressure, and widening pulse pressure, your Cushing's triad. As the brain compression increases, respirations become rapid, and the blood pressure may decrease, and the pulse become even slower. This is an ominous development, as is rapid fluctuation in vital signs. So if we see this, that's no bueno. So the nursing process for this assessment of brain injuries, we want to do a thorough health history if possible, with a focus on the immediate injury though. So what happened? We want to know the mechanism of injury. Was it a fall, ground level fall versus a fall from a second story is very different. So mechanism of injury, when did the injury occur? What direction was the force, right? So it's a difference between when we talk about motor vehicle accidents, like a head-on versus a T-bone. And what are our signs and symptoms at that time? So, and we'll do a baseline assessment. Look at your figures, figure 68.4 in your book, and table 68.1 will tell you more about the health history. Your baseline assessment, go to 68.3. If we suspect a stroke, remember we'll do the Glasgow, the NIHSS. We'll use the Glasgow Coma Scale for assessing level of consciousness. We want to do frequent and ongoing neurological assessments to hopefully early detection of any changes in cerebral pressure or their neurological function. And then a multi-system assessment. Oops. Again, some of the supportive measures for patients with a head injury. They may need respiratory support, including intubation and mechanical ventilation. And we've talked about that. Seizure precautions and prevention. So any patient with a head injury is at risk for seizures. So you'll have the seizure pads, and some they may give prophylactic anticonvulsant medication if necessary. We don't want to sedate patients, so we don't want to go like Versed or Ativan for preventing seizures, because it'll affect our ability to perform our neurological exams, right? They may have an NG tube to manage reduced gastric motility rates, to prevent aspiration. And they may eventually need that for nutritional support. But remember, basal skull fracture, no NG tube. We want to manage pain and anxiety and maintain their fluid and electrolyte status. So again, just like we talked about, that ongoing assessment and monitoring of vital signs, level of consciousness, maintain airway, and assessment of motor function. Important. We'll do daily INOs, daily weights, monitor blood and urine electrolytes and osmolality and blood glucose, measures to promote adequate nutrition. So if we're concerned about swallowing difficulties, then we'll have to have those consults made, whether it's speech pathology, and give them the appropriate diet. If they can't eat or drink, then we'll need to support that either with parenteral or enteral nutrition. Strategies to prevent injuries, so assessment of oxygenation, assessment of bladder and urinary output. Remember all these things that are in our brain, and head injury puts us at risk for SIADH and diabetes insipidus, which have a lot to do with our urinary output and electrolyte composition, particularly with sodium. So we'll want to be monitoring that for signs of these potential complications, and that we treat them immediately and appropriately, right? Assessment for constrictions caused by dressings and casts. So remember, anytime we have to put on any kind of cast or dressing, especially if it's circumferential, we want to assess CMS distal to where this is. So we may have splints and casts put on to support body alignment and on a flaccid limb. So we want to make sure that we're assessing distal to that. We want to remove and look under the cast and assess the skin every 2 hours. Pad the side rails, that's your seizure precautions. We want to avoid restraining these patients, and we talked about that last week. Pulling on the restraints can greatly increase your ICP. So you can do mittens. They look like boxing gloves that can help you stop them from pulling it at lines and injuring themselves. To help reduce the progression of this, we want to reduce environmental stimuli. So if you're having the ICU, things like oftentimes you'll see patients in the ICU and they have their monitors are beeping and squeaking and going off, and even in the room. If you're monitoring them outside, you can have the monitor on and turn the sound down in the room. That'll decrease the stimulation and may help reduce anxiety. You want to have adequate lighting to reduce visual hallucinations. Measures to minimize disruptions in sleep cycles. So this is huge. These patients are often in getting serial assessments, neurological assessments, and then they have meds to give, and then they have this to do and that to do. So with that, when we say measures to prevent disruption of the sleep cycle, if you're going in to do an assessment, cluster that with another activity whenever possible. I have to wake you up for the assessment to see how you're doing, but maybe I can turn you at the same time and hang your antibiotic, that sort of thing. Want to do meticulous skin care, making sure that we're assessing their skin regularly and preventing any skin breakdown, taking proper measures to prevent infections. Remember, if you have any opened head wounds, so break in the skin and the skull, that they'll be on antibiotics. We want to administer them as ordered and monitor them as required. We want to make sure we maintain body temperature. Remember, increases in body temperature can increase metabolic demand at a time when we have a limited supply, especially in the brain, right? So temperature is maintained at less than 38 degrees Celsius or 100.4. We can use, make sure that the We also want to avoid shivering, because shivering, if you get too cold, again, increases metabolic demand. So we want to maintain appropriate environmental temperature. And so the room shouldn't be too hot or too cold. Use blankets and sheets to the patient's needs. Administer Tylenol as needed for fever. If they do have a fever and the Tylenol is ineffective, we can use cooling blankets. And again, we want to avoid the shivering. So we want to, in patients who are having some cognitive difficulties, support their cognitive function, reassess to reality, reorient to date and time and what's happening, be patient with repeated questioning, but note it, that sort of thing, right? Want to support the family to provide and reinforce information. Make sure that we're providing information about how to visit, that sort of stuff. Measures to promote effective coping. So making sure that we're setting realistic short-term goals and well-defined goals that can help can really help a family cope. Unrealistic goals can be crushing, so make sure that we're being realistic. Referral for counseling or support groups if there is permanent damage. There are great local support groups in most areas. And then patient teaching and families, family teaching. So there may be, if the patient comes out with neurological deficits, teaching for how to use assistive devices, new ways to walk. They may have swallowing difficulty, speech pathology may see them, so we need to reinforce information provided by physical and occupational therapy. They'll may be on new meds. We teach them about the meds they're going to need, the follow-up appointments they'll need to make, the standard, everything you need to do with discharge. All right, so we're on to spinal cord injury. So about 276,000 people in the United States live with some sort of disability from a spinal cord injury. Causes could include motor vehicle accidents, falls, violence, whether that's assault, gunshots, that sort of thing. Sports-related injuries can cause spinal cord injury. Males account for about 80% of all spinal cord injuries, as they tend to be, generalized statement here, but more impulsive, bigger risk takers, involved in more high energy, what's the word I'm looking for? I'll go with high risk sports, skydiving, that sort of thing, right? However, the average age, surprisingly, of injury is 42. You would think by then you'd have gotten a little more out of your system. Risk factors include young age, male gender, alcohol, and drugs. Alcohol and drugs can inhibit our we don't always think as clearly, so we become bigger risk takers, right? And again, as with head injury, we want to work on primary prevention. Wear your seatbelt if you're riding a motorcycle, wear your helmet. Don't dive into an area of water where you don't know the depth, that sort of thing. So spinal cord injury is the result of a concussion, contusion, laceration, or compression of the spinal cord. So this is some sort of damage to the central nervous system, your spinal cord, right? The primary injury is the result of the initial trauma, and usually permanent. And secondary injury in spinal injury, much like secondary brain injury, is the result from edema or hemorrhage at the site. So it's not the damage of the cause of the initial injury. That may potentially be reversible, and we want to try and avoid that if at all possible, right? Spinal cord injuries are a major concern for critical care nurses. Treatment is needed to prevent partial injury from developing into a more extensive permanent damage. So all our treatments are aimed at preventing that secondary injury or dealing with it quickly. So spinal shock, this is a sudden depression of reflex below activity below the level of the spinal injury. Right? So this is what you'd see after the initial injury. Right? I can't move my legs. Right? So you could have flaccidity, loss of sensation or reflexes. And that because the nerves distribute out from the spine, so everything that happens below the level of injury is now blocked. Now, neurogenic shock, this is caused by the loss of function of the autonomic nervous system. Remember, this is the part of the nervous system that is responsible for control of the bodily functions that aren't conscious directed, right? These are things we do unconsciously without thinking, such as breathing, heartbeat, and digestive processes. So neurogenic shock causes a loss of function of the autonomic nervous system. Blood pressure, heart rate, and cardiac output decrease, right? So you get bradycardia, you get low blood pressure, and decrease related to the decreased cardiac output. Now remember, normally in your shocks, as you get hypovolemic, the first thing your heart does is speed up to compensate. But we've lost that kind of autonomic control, so we get bradycardia. So this is a change, this is a difference from most of your shocks. So I would remember that, bradycardia and hypotension. You get venous pooling that occurs because of peripheral vasodilation, right? So you're not able to, not all, but a fair amount of your blood is pooling in your periphery. And the paralyzed portion of the body does not perspire. So you may have diaphoresis or some sweating in the non-paralyzed parts, but you will not in the paralyzed parts. So autonomic dysreflexia, this is an acute emergency. And this occurs well after the initial injury, right? So this occurs after spinal shock is resolved, and it may occur after years after the injury. This occurs in people with spinal cord lesions above the level of T6, and the autonomic nervous system responses are exaggerated. So symptoms include a severe pounding headache, a sudden and severe increase in blood pressure. So this is just a massive shift in blood pressure. They have profuse diaphoresis, nausea, nasal congestion, and bradycardia. So the autonomic dysreflexia is different than neurogenic shock, and that neurogenic shock is bradycardia and hypotension. This is bradycardia and hypertension, along with the other signs, right? This is triggered by most commonly a distended bladder, but it can be distension or constriction of visceral organs, so like constipation, or stimulation of the skin, so tight clothing, tight restrictive clothing below the level of the injury, having a pressure ulcer, not turning, that sort of thing. So what do we do about this? So we want to place the patient in a seated position to lower the blood pressure. We want to do a rapid assessment to identify and eliminate the cause. So sometimes with patients at home, this may be they missed a self-cath if they're self-cathing. So always check for the distended bladder. If they have a Foley in their hospital, is it draining properly? Is it below the level of the patient so it's draining? Is it clogged? Are they constipated? Is there a fecal mass? Then we'll need to disimpact, examine the skin to see if there's any. So with patients who are newly in the hospital, are our bandage, do we have a splint or traction or something that's constricting? So we want to do that. They may need to administer ganglionic blocking agents such as hydralazine, hydrochloride, IV. You will label the chart or medical record that the patient is at risk for this so that people are extra careful, and instruct the patient in prevention and management. So they'll need to know the signs and symptoms at home, what triggers it, right? And what to do. They'll need to call 911, but if you're at home and you call 911 and they're coming, you can self-cath if that tends to be the issue. So for assessment for patients with spinal cord injury, we want to maintain C-spine, so they'll come in with the collar, and we'll maintain body alignment. Testing will be done, right? But we want to monitor for respiration and breathing patterns. So depending on where the injury is, remember how this innervates, the higher the injury, the more likely you have respiratory issues. But we'll monitor respiratory and breathing patterns, lung sounds. We want to make sure that the patient is participating in pulmonary toileting. We want to avoid pneumonia as a secondary complication. So incentive spirometer, deep breathing, coughing, sort of thing. Remember, we won't necessarily be going and we won't be percussing the back if we have a spinal cord injury, an acute spinal cord injury, but we can take other measures, right? So assess for spinal shock, right? So how do we do that? Well, we would do a neurological assessment. Is there any motor or sensory deficit? Document at what level, that sort of thing. Monitor for bladder retention and distension, gastric dilation, and ileus, right? Because these can cause autonomic dysreflexia. So we want to monitor for and prevent these, and make sure that we're doing frequent temperatures. So at least every 4 hours with our temperature. Potential complications include DVT, orthostatic hypotension, and autonomic dysreflexia. So we want to make sure with these patients we change positions slowly, have DVT prophylaxis on board, and try and avoid autonomic dysreflexia, and if we see it, treat it early. So is the following question true or false? Never massage the calves or thighs of the patient because of the danger of dislodging an undetected DVT. That is true. Don't do that. All right. So promotion of effective breathing and airway clearance in patients with spinal cord injury. Want to monitor carefully to detect the potential respiratory failure. So there may be continuous pulse oximetry, ABGs if indicated, arterial blood gases, frequent monitoring of lung sounds, early and vigorous pulmonary care to prevent and remove secretions. So again, hopefully we can prevent these issues, but if they're on oxygen, you may want to consider using humidified oxygen. Make sure that the patient maintains a good hydration status. This will help liquefy any secretions so that we can get them out. Have the patient do the coughing and breathing exercises. We can suction, but we want to be very cautious of doing that. You think about what happens with all that going on, right? The breathing exercise we talk about. If they do cough, we can assist with coughing, as maybe they need to splint an area, something like that. You can have suction at the bedside, but be very careful. So improving mobility. So in the acute phase, right, we will keep them in C-spine. If they've done some sort of intervention or when they say we can, we'll indicate, start moving the patient as soon as possible. We want to maintain body alignment initially. We want to turn only if the spine is stable and as indicated by the physician. So if we have not stabilized the spine, we won't turn their specialty beds they can use to help prevent skin breakdown. But if the spine is unstable, we don't want to turn them and further damage the spine. Monitor blood pressure with position changes. So remember, they're at risk for orthostatic hypotension. So if you're sitting the patient up, you want to do so slowly, again, and only when the spine is stable and you have orders where you can. Sit them up slowly and then check their blood pressure. Right? Want to do passive range of motion at least 4 times a day. Use assistive devices, whether that be a neck brace or collar as prescribed when the patient is mobilized. So if this is ordered, make sure you use it. Move gradually to the erect position. We talked about that, and check the vital signs when you get there. So this is just a picture of a halo system for cervical and thoracic injuries. So this is used to keep the head and neck aligned in a lot of like cervical injuries. Here along here, you'll notice they'll have, well, maybe you can't see them, but there are pins that actually go into the skull and hold the head in place, so they can't, do this. It keeps all of this in line. So you'll need to know how to do pin care, and I think we talk about that here in a little bit. So still taking care, we want to make sure we use strategies to compensate for sensory and peripheral and perceptual alterations. So if there was an some sort of injury, now they can't feel below that area. So having them put themselves on a schedule, we can turn them in the hospital, but how are they going to take care of that at home? So we need to start teaching them that you can't feel this now. You can't feel your bladder distension. You don't know that you have to pee. So that would be a bowel and bladder program. So whether that's self-cathing, how to self-cath, or if it's an indwelling catheter in the hospital setting. NG tube we may need to relieve gastric distension. They'll want a high calorie, high protein, high fiber diet. Remember, high fiber, we don't want this patient to be constipated, so they'll be on a high fiber diet, probably on stool softeners. We'll need to do traction pin care, so that's the pins that went in here, and usually they will clean those as ordered. It's usually half strength peroxide and normal saline, and they'll clean around there. We also want to make sure that we're taking care of these hygiene for underneath casting or underneath any of these traction devices. And again, so that could be pin care, that could be cleaning underneath the shoulder harness for your halo, that sort of thing. So a patient with a spinal cord injury at T5 begins to complain of severe headache and is diaphoretic and nauseated. Which nursing intervention would not be appropriate? So place the patient immediately in the sitting position, lower the patient to a flat side-lying position, assess for bladder distension, assess for the rectum for fecal mass. So which of those? What's your answer? So the answer is B. Lower the patient to a flat side-lying position. Remember, read carefully which would not be appropriate. So we're looking for a negative answer. And we just went over this, so we should know that we want to sit them up and assess the bowel and bladder, so we know those 3 are right and this is wrong. But if we knew nothing about this, sitting them up and lying them down are polar opposites. So one of those is wrong, right? If you know nothing, you got a 50-50 chance. One of those, it's A or B. We know a little bit, so we know the P was wrong. All right, so we're going to talk about the management of patients with uh, neurologic infections, autoimmune disorders, and neuropathies. Okay, so infectious neurologic disorders that we're going to talk about are rather meningitis, brain abscesses, and encephalitis. So meningitis is just an inflammation of the membranes and fluid space surrounding the brain and spinal cord. Um, there are two main types, so septic and aseptic. So septic is caused by bacteria, usually Streptococcus pneumoniae or Neisseria meningitis. I think that's how it's pronounced. I'm terrible with pronunciations. And aseptic is caused by a viral infection, can be secondary to cancer or a weak immune system, um, or not. So that puts you at risk, right? So the meningitis, this is transmitted by secretions or aerosol contamination. And the infection is most likely where you have dense community groups, um, such as college campuses. Right? Uh, it can run through a sports team quick. So if you're in close quarters, manifestations include headache, fever, uh, changes in level of consciousness, behavioral changes, um, nuchal rigidity. So fever and nuchal rigidity should perk you up a little. Remember, nuchal rigidity is that stiff neck. They may have a positive Kernig's or a positive Brudzinski sign, and photophobia. Don't confuse Brudzinski with Babinski. Brudzinski is different. Yeah, I know. Everything sounds a lot alike. So, medical management. So we want to prevention if possible. There is a vaccine. So prevention by meningococcal vaccine to children 11 to 12 years old, a booster at 16, and then they'll do it the first year of college students, and members of the military should also receive um, the vaccine to help prevent, right? Military is another group that lives pretty close together, right? Um, if we can't prevent it, so the other management is early high doses of appropriate antibiotics for a bacterial meningitis. Um, they may do acyclovir for so that's an antiviral for management of viral. May use dexamethasone. That can help. Dexamethasone is a steroid to decrease inflammation. And we want to treat dehydration, shock, and seizures, right? So supporting blood pressure, supporting vital signs, seizure precautions if indicated, that sort of stuff. So the nursing management is frequent and continual assessment, including vital signs and level of consciousness. Pain and fever management. Remember, we want to control these fevers. This can be very painful, so pain management. Protect the patient from injury related to seizure activity. This is your seizure precautions. Monitor daily weight, serum electrolytes, urine volume, specific gravity, and osmolality, right? This may be important for potential complications, right? Infection control precautions. So do these patients need to be on be isolated? Supportive care. So again, supporting any sequelae that come after this, and measures to facilitate coping of friends and family. So this can be very serious. And we talked about the Kernig's sign. So this is how you perform it with a patient lying flat. You'll want to move your leg up, and then you'll get pain with that. And here's your Brudzinski's sign. So other infective brain issues, so a brain abscess. So this is a collection of infectious material within the brain tissue. So an abscess is usually a localization of this kind of purulent drainage rather than a widespread infection, right? Bacteria is the most common causative organism. We can prevent some of these cases by treating otitis media, rhinosinusitis early, so these don't cause travel into the brain. Right? Manifestations include headache that is usually worse in the morning. Right? Headache worse in the morning, fever, vomiting, neurological deficits depending on the size and how quickly this abscess grows. Signs and symptoms of increased inner cerebral pressure. Remember, head's a box, contents are enclosed. If we're getting a collection of drainage, there's nowhere for the brain tissue and blood to go. Potentially, you can have some alterations in cerebral spinal fluid levels to compensate, but again, keep an eye on that, right? So this is diagnosed usually by MRI or CT to visualize the infection. Medical treatment may include a guided aspiration to aspirate the contents and identify the causative organisms, right? So we want to take out that collection because remember in the middle of that, if you have an abscess, just like with the skin abscess, you don't necessarily just treat it with antibiotics because you have this abscess and your blood supplies out here around the abscess, and your antibiotics will be in this blood supply, so they'll treat the stuff on the surface, and then the stuff in the middle is just kind of festering. So we want to drain that. We'll send it off for a culture and sensitivity so that we have make sure that the antibiotic that we're giving treats the organism that we're looking for. Remember that whole blood-brain barrier thing, so that can be an issue too. So medical management is the control of the inner cerebral pressure, draining the abscess, administering appropriate antibiotic therapy. Corticosteroids may be used to treat cerebral edema. The nursing management is frequent and ongoing neurological assessment, timely administration of ordered medications, usually antibiotics and other meds, monitoring for their effectiveness, assess their response to treatment, right? So that's managing, are they getting better? And how would we assess that? So improving neurological status, decrease in white blood cells, absence of fever, right? And then provide supportive care to support any potential sequelae that come from this. So encephalitis is an acute inflammation process of the brain tissue. Causes include viral infections, so herpes simplex virus, vector-borne viral infections like West Nile virus, and less common fungal infections. The manifestations may include a headache, fever, confusion, hallucination. If you have if herpes simplex or West Nile is the cause, you may have a rash, flaccid paralysis, Parkinson's-like movement is potential signs and symptoms. Medical management is acyclovir for the herpes simplex virus, acetaminophen or amphotericin, not Tylenol, amphotericin or other antifungal agents for fungal infection. And again, we manage the fever with acetaminophen or Tylenol. The nursing management is the same as the others, right? Frequent and ongoing assessments, administration of ordered medications on a timely schedule, and supportive care. All right, so now we're going to move on and talk about autoimmune and neurologic disorders. We'll talk briefly about MS, myasthenia gravis, and Guillain-Barré syndrome. So, is the following statement true or false? Multiple sclerosis is an immune-mitigated, progressive, demyelinating disease of the peripheral nervous system. That's false. Multiple sclerosis is an immune-mitigated, progressive, demyelinating disease of the central nervous system, not the peripheral nervous system. So you'll see why that's important later. Right? So we said that a progressive immune related demyelinating disease of the central nervous system, which results in so the myelin breaks down. This is the insulating cover of the nerve cells in the brain and spinal cord are damaged. The damage disrupts the ability of parts of the nervous system to communicate, and this results in a wide range of symptoms. Difficulty in coordination is often the symptom that prompts a patient to seek evaluation, but specific symptoms can include double visioned, blindness in one eye. It's usually muscle weakness and trouble with sensation or coordination. And again, the trouble with coordination is usually what prompts people to seek evaluation. So MS can take several forms, with new symptoms either occurring in isolated attacks, so this is a relapsing form, or building up over time. This is the progressive form, right? So it could be remittent and reoccurring, or progressively getting worse. Between attacks, symptoms may disappear completely, or they may just stop progressing and stay, or get slightly better and stay that way for a while and then reoccur. However, permanent neurologic problems often remain, and especially as the disease advances. Medical management for the disease is disease-modifying therapy, so interferon beta A1 and interferon beta 1A, interferon beta 1A and interferon beta 1B. Glutamate acetate may be given, or IV methylprednisone can be given. Symptom management for muscle spasms, fatigue, ataxia, and bowel bladder control, if we have involvement there, is important. So we want to, for assessment, we want to assess what their neurological deficits are, and do a history of what their disease process was, how it's progressed, where they're at, right? We want to assess for secondary complications. We want to assess the impact of the disease on physical, social, and emotional functions and on lifestyle. So are they able to perform their ADLs independently? Can they still work? Is their house still functional for them? This can be an issue with, there's a lot of stairs, or it's a second story and your bathroom's on the second story and you're having locking issues, that sort of thing, right? And how is the patient and family coping with this? And we want to support those measures, right? So care for this, our interventions, we need to use a collaborative approach. Coordinate and refer as needed to healthcare services, social services, speech, occupational therapy, counseling service if they need it. Do they need any home health care, and so on. For activity and rest, we want to keep patients as independent and active and independent for as long as possible. So a program of activity and daily exercise, relaxation and coordination exercises, walking, muscle strengthening exercises These are usually prescribed through physical therapy in the inpatient setting. They may see a physical therapist in the outpatient setting. In the inpatient setting, we need to be reinforcing this education and assisting the patient and providing their own care whenever possible. And while we want to have a program of daily exercise, we do want to avoid very strenuous activity and extreme fatigue. Extreme fatigue can exacerbate your symptoms, so be aware of that. So they may need bowel and bladder control. They may we want to instruct or administer the administration of prescribed medications. So what is their medication schedule on the hospital will be administering it when we want to make sure that they can self-administer when they go home. We may need to teach them about a voiding schedule or put them on a bowel training program if we're having those involvements, right? Adequate fluid and fiber to prevent constipation, potentially maybe on the stool softener. We want to reinforce and encourage swallowing instructions. So if they're having some swallowing difficulty, collaborating with our speech pathologist to make sure that they have the proper diet order. Do they need thickened liquids? Do they need soft food? Are they just teaching them swallow strategies? So remember tucking your chin to swallow, that sort of stuff. If we're having swallowing difficulties, we want to take strategies to reduce risk of aspiration, sitting the patient upright and preferably out of bed to eat. Head of the bed 30 degrees, suction by the bedside, that thing. They may need memory aids as their disease progresses. It can be such things as having a structured environment. Daily routines can help enhance cognitive function. If they're on medications, having a weekly pill box. Maybe you have home health come by and fill out their pills for the week, and then they're able to just take them that way. We want to use interventions to minimize stress. Stress can be a trigger for a flare-up. We want to try and avoid stress as much as possible. Maintenance of a temperate environment, so air conditioning, to avoid excessive heat and avoid exposure to excessive cold. Use assistive devices and modifications for home care and management of independent ADLs, and support coping, whether that be through therapy. Do they need a support group? Would that help them? And include the family in all this, because this disease really does affect not just the patient, but the family as well. Know their role in the family, and if that role is disrupted, how that can stress the whole situation. All right, myasthenia gravis. This is an autoimmune disorder affecting the myoneural junction, right? So MS is the demyelinization of the central nervous system. This myasthenia gravis is an autoimmune disorder, but this affects the myoneural junction, right? Antibodies directed at acetylcholine at the myoneural junction impair transmission of impulses. So the signs and symptoms of this: initially, symptoms involve ocular muscles. All right, so diplopia or ptosis, right? So the pathologic kind of droopy eyelid. This is different. So this is something I would know. This is how I can differentiate these three diseases we're talking about, is finding the differences, right? Weakness of the facial muscles. So this usually starts in the face. So swallowing and voice impairment. So they may have some dysphonia, and generalized weakness are all signs and symptoms of myasthenia gravis. This image kind of shows you the degeneration of the acetylcholine receptor sites in myasthenia gravis versus normal acetylcholine receptor sites. So if you like the visual, there you go. So the medical management is directed at improving function and reducing and removing the circulating antibodies. So pharmacologic therapy is anticholinesterase medication and immunosuppressive therapies. So anticholinesterase is any of several drugs to prevent the destruction of the neurotransmitter acetylcholine by the enzyme acetylcholinesterase within the nervous system. Myasthenia gravis is generally treated with medications known as acetylcholinesterase inhibitors. So your anticholinesterase, such as nystigmine, protostigmine, immunosuppressants such as prednisone may also be used. And then there's, in rare cases, they may do a removal of the thymus, may improve symptoms in some cases. Plasmapheresis and high-dose intravenous immunoglobulin may be used during sudden flare-ups of the condition. Oops. Where was I? There I am. Okay. So management of patient education and the signs and symptoms of myasthenic crisis and cholinergic crisis, because this is a potential complication. We'll talk about what those signs and symptoms are in a minute, but they need to know those signs and symptoms, right? Ensuring adequate ventilation, so supporting, making sure that we support the other vital functions. Assessment and supportive measures of airway, respiratory system, monitoring, serum electrolytes, INO, daily weights. If the patient has swallowing difficulties, we need to make sure that speech pathology is involved and that we follow their orders and reinforce their education. Continue to monitor as they may eventually become unable to swallow. And in that case, they may need an NG tube, may be required to help with nutrition. We want to avoid sedatives and tranquilizers in these patients. And, here we go. Here's the myasthenic crisis and cholinergic crisis. So the myasthenic crisis is the result of a disease exacerbation or a precipitating event. Often the precipitating event of this crisis commonly is a respiratory infection. Where a cholinergic crisis is caused by over-medication with cholinesterase inhibitors, right? So if you get too much of the medication to treat your myasthenia gravis, you can go into this. So your signs and symptoms are severe muscle weakness with respiratory and bulbar weakness, right? And patients may develop respiratory compromise and failure. The treatment is slightly different, right? In a cholinergic crisis, should be treated by withdrawing all anticholinesterase medication. Mechanical ventilation may be required. They may use atropine for the muscarinic effects of the overdose. And obviously in the myasthenic crisis, it may not be so much of an overdose as it is treating the triggering cause. All right, Guillain-Barré. This is an autoimmune disorder with acute attack on the peripheral nervous system. So multiple sclerosis is central, Guillain-Barré is peripheral. And this has a rapid demyelinization, which kind of manifests in an ascending paralysis. The manifestations vary and include weakness, paralysis, paresthesia, pain, diminished or absent reflexes. And again, this is ascending. So it starts in the lower extremities and moves its way up. And it can be relatively mild to extremely severe. We were required in nursing school to read a book called Bed 10. It's about a patient who had Guillain-Barré syndrome and was in the ICU for several months. Really good book. If you're going to work in the ICU, I suggest you read it. it's kind of from the patient perspective, so it's not going to help you pass any of these tests, but it gives you really good insight into what patients in ICU deal with. So Guillain-Barré, this is a medical emergency. It requires intensive care management with continuous support, monitoring, and respiratory support. May do plasmapheresis and IVIG are used to reduce the circulating antibodies. Recovery rates vary, and as does the severity, but most patients recover completely. Now, when we talk about MS and the demyelinization, and that's progressive and permanent, why is Guillain-Barré, why do these patients recover? Is it because of peripheral nervous system or, yeah. Well, Guillain-Barré spares the Schwann cells on the peripheral nervous system, which allows for remyelinization in the recovery phase of the disease. And I think, no, one point I missed, which is rather important, and I apologize, is Guillain-Barré. It often follows within a few days or weeks after the patient has a viral infection. So your body goes and fights that, and then it kind of, I won't say overreacts, but usually that's the triggering cause. All right. So potential complications can be respiratory failure, autonomic dysreflexia, DVT, pulmonary embolus, urinary retention. So we want to prevent and monitor for signs and symptoms and treat quickly any of these complications. So respiratory care, we want to do respiratory exercise as long as they can. They may end up intubated. Autonomic, not dysreflexia, autonomic dysfunction. So we want to make sure we're monitoring our vital signs and being supportive of any measure that's inappropriate. Hypotension, we could treat with fluids or pressors, that sort of thing. DVT prevention, pulmonary embolus prevention, and avoiding urinary retention. So assessment of Guillain-Barré, so ongoing assessment with an emphasis on early detection of life-threatening complications, the respiratory failure, dysrhythmias, DVT, right? So we want to prevent these. I know it sounds a little redundant, but kind of treat most of these the same with slight variations, right? Monitor for changes in vital capacity and negative inspiratory force. So this is our respiratory assessments. They may be on continuous pulse ox as their respiratory system becomes involved. However, remember that pulse ox isn't the best indicator of hypoventilation. That's why they say talk about vital capacity. You can also use end-tidal CO2 monitoring. It's an earlier sign of hypoventilation, much earlier sign than hypoxia. So assess vital signs frequently and continuously, including continuous ECG monitoring, and we want to support patient and family coping. To enhance physical mobility and prevent DVT, we want to keep them mobilizing as long as they can mobilize. The measures that we use, standard measures, whether that be SCDs, heparin or low molecular weight heparin for DVT prophylaxis, supporting limbs in the functional position, passive range of motion at least twice a day, frequent position changes at least every 2 hours to keep the skin intact, adequate hydration, administration of parenteral or enteral nutrition as appropriate, and careful assessive swallowing and gag reflex and measures measures to prevent aspiration. Early on, make sure we get speech pathology involved, and then they may progress from there, and then they may need to come back and retrain them as their sensation and movement comes back. So develop a plan for communication with individualized patient needs. In the Ben 10 story, that was really her big takeaway was her inability to communicate, and how to, she couldn't push a call bell. She had severe and was intubated, severe Guillain-Barré. And as she started to get movement back, she was able to communicate with like um, a bell on her thigh when she could just contract her thigh muscle, and she could knock the bell off and call for help. So again, interesting book. But as since this is a progressive paralysis, um, when the patient comes in and we can still communicate with them, trying to figure out some sort of plan that's going to work for both of us to communicate should they be unable to communicate later is very important, right? We want to decrease fear and anxiety, so provide education and support for the family. Again, this usually resolves. Don't make promises. This can take a long time, so be realistic. Set realistic short-term goals. Uh, Refer to support groups. Even for the family while the patient's in the hospital, and then they may have a lengthy recovery afterwards, so they may need support groups, relaxation measures, um, and so on. So we're going to talk about a couple of cranial nerve disorders. We're going to talk about trigeminal neuralgia and Bell's palsy. So trigeminal neuralgia is a condition of the fifth cranial nerve. It's characterized by unilateral kind of face pain. The most commonly occurs in the second or third branches of the nerve. It occurs more often in the fifth and sixth decades in women and in persons with MS. So clients that develop trigeminal neuralgia before the age of 50 should be evaluated for coexisting MS, because trigeminal neuralgia occurs in approximately 5% of patients with multiple sclerosis. So be aware of that. It's in red. It's probably important. So pain can occur with any stimulation, such as just washing the face, brushing the teeth, eating. Even a draft of air over the area can cause pain. So patients may avoid eating. They may neglect hygiene or even isolate themselves to prevent attacks. So the medical management is they may do. Well, remember in pharm when we talked about anti-seizure medications, and a lot of those are used for things other than seizure. This is one of the cases. So they may be given carbamazepines or Tegretol or gabapentin, or phenytonin or antispasmodic medication, baclofen. So it depends on what their signs and symptoms are. Neurontin's a good good for neuropathies, for these neuro pain. Surgical treatment can include microvascular decompression of the trigeminal nerves. They go in and do like a microsurgery. They can do a radiofrequency thermal coagulation, or percutaneous balloon microcompressions. They go in and kind of balloon. We want to take the pressure off that nerve. So for nursing interventions, we want to do patient education related to pain prevention and treatment regime, measures to reduce and prevent the pain, such as avoiding the triggers, whether it's hot and cold food. If chewing does it, maybe a soft diet, chew on the unaffected side, care of the patient, experiencing chronic pain. So we want to also look for signs and symptoms of depression, and treat those early. We want to take measures to maintain hygiene, find ways to provide good oral care, and still be able to wash the face. And we want to recognize and provide interventions to address stress, depression, anxiety, and insomnia. Insomnia is huge. We want to make sure that these patients are still being able to sleep. Insomnia makes everything worse. If you're not sleeping, the pain gets worse. It's harder to control. We have less patience to deal with it. So sleep rest pattern in all patients is important. So Bell's palsy, this is facial paralysis caused by a unilateral inflammation of the seventh cranial nerve. This manifests in a unilateral facial muscle weakness or paralysis. So you get the face droop. You may have increased lacrimation. You may have pain sensation to the face. You may have difficulty with speech and eating. Remember, if we have, this is primarily a cranial nerve thing, but anytime you have a facial droop, we need speech pathology come in, make sure you can still swallow. Most patients recover completely in 3 to 5 weeks, and the disorder rarely recurs. Oftentimes, these patients will come in to the ED, and their concern is that they're having a stroke. So we need to reassure them that they're not, right? So the medical management is corticosteroid therapy may be used to reduce inflammation and diminish the severity of the disorder. This is often the result of a viral infection. So antiviral medications may be given, but we want to provide and reinforce information and reassurance that a stroke has not occurred. You have now had a stroke. This isn't permanent neurological damage. We need to protect the eye from injury, right? If we have this, the drooping of the side of the face, they may not be able to close their eyes properly. So you want to cover the eye with a shield at night if necessary, instruct the patient to close eyelids, and the use of any ointments or eye lubricant. They'll need to wear sunglasses to prevent the eye from any radiation damage. Facial exercises and massage to maintain muscle tone. So as this goes down, are they able to do any? They'll have some paralysis, but what muscle exercises you can do to retain the muscle tone until it comes back. All right, take a second here, and then we're getting close to done. We'll talk about the management of patients with oncologic and degenerative neurologic disorders momentarily. And we're back. Okay, so we're going to talk about oncologic tumors. So these brain tumors can be, because we're talking about the central nervous system here. So brain tumors, they could be benign or malignant. They are classified based on their location and histologic characteristics. Types of primary tumors include gliomas, meningiomas, acoustic neuromas, pituitary adenomas, angiomass, so these are masses of abnormal blood vessels, and metastatic tumors. So metastatic tumors are a cancer that started in one portion of the body and has now metastasized or traveled to another part of the body. We'll also talk about spinal tumors, again, central nervous system. So these are classified according to their anatomic location to the anatomic relation to the spinal cord. So if they're intramedullary, this is within the spinal cord, or extramedullary. So intra is inside, extra is outside. So this is epidural, outside the dural, extradural, outside the dural membrane. Manifestations vary based on where the lesion is, but they include pain, weakness, loss of motor function, loss of reflexes, and loss of sensation distal to the lesion. So the higher up the lesion, the more complications you have. Right? Treatment depends on the type of tumor and the location. They include surgical removal when possible, measures to relieve compression. And so if you're unable to remove it, you can do dexamethasone combined with radiation. They may do, if they can't remove all the tumor, sometimes they will remove part of it and then do radiation. So they'll do a debulking and then radiation if it's indicated. So with brain tumors, the symptoms depend on the location and size of the lesion and what it's affecting, right? So left-sided tumors, left-sided tumors in, oh, that's the right side. Left-sided tumors in this area may cause speech problems. Again, it depends on what it's hitting, right? They may have symptoms of increased intercerebral pressure. So we need to remember, as the tumor gets bigger, there's only so much space in the head. So we need to remember those signs and symptoms of increased ICP. Comes up a lot, should probably know them. They may have headache, vomiting, visual disturbances. They're at risk for seizures, so seizure precautions. May have hormonal effects with a pituitary adenoma. And when we get into the system, we'll kind of get into more of what those are when we talk about the endocrine system. We have loss of hearing, tinnitus, vertigo with these acoustic neuromas. So make sure we're aware of that. So here's an image that shows you the common sites of the different where brain tumors may be, common sites of brain tumors. Sorry, had a moment. Diagnostic evaluation, so history and physical, your neurological exam. They may do a CT, MRI scan to determine the location, PET scan, EEG. If they present with seizures, they'll do an EEG. They may do cystology studies of the cerebral spinal fluid. So they may do a spinal tap and look at the cells in there, looking for any sort of cancer cells in the circulating fluid. Biopsy of the mass to determine if it is benign or cancerous. Medical management, so specific treatment depends on the type, location, and accessibility of the tumor, right? So we can do surgery. The goal is to removal of the tumor without increasing neurological symptoms or to relieve symptoms by decompressing the tumor. So we could do the craniotomy, right? We could do a transpharyngeal surgery, so it's kind of where they go up through the nose, and they can do the stereotactic procedures. This is where they'll kind of map the tumor and do radiation therapy. It's a cornerstone treatment for many brain tumors. A lot of brain tumors we can't actually get at, so we'll map where they are and do radiation therapy, targeted radiation therapy for that. They do chemotherapy or other pharmacologic therapies as necessary. So that could be aimed at decreasing the swelling around there, the area, whether that's steroidal therapy, that sort of stuff. So the care of the patient with a cerebral metastasis or inoperable brain tumor. So we want to do, if they have an inoperable brain tumor or they have a brain mets, this may, again, depending on the patient. So we want to do a baseline neurological assessment, which focuses on their function, moving, walking, adapting to weakness and paralysis, and to the potential loss of vision or speech, and dealing with seizures. The prognosis for these may be bad. This isn't every patient. There are some inoperable brain tumors that are found incidentally with something else that aren't growing that really don't cause this. But most of these patients may be terminal. So we want to deal with, make sure that they get good, oh God, I'm having a moment here. It's the word I'm looking for. Palliative. There it is. Found it. Good palliative care. We want to make sure that we're treating their pain, their respiratory systems, bowel and bladder functions, sleep, skin integrity, fluid balance, and temperature regulation. Do nutritional status and dietary history. How's their family coping and their family processes. These intercerebral metastases who are not treated will have a steady downhill course with limited survival time, whereas those who are treated may survive slightly longer periods, but but for most, a cure is not possible, so the palliative care is very necessary, and this is the priority over promotion of function. So we want to do all this, but if we know that they're may not survive, we need to aim towards the palliative care. And again, this is patient-directed how they want to do it. They may need to potentially consider doing an advance directive so that their wishes are known when and if they become, or if and when they become unable to make verbalize their choices. So some interventions for improving nutrition, oral hygiene before meals, plan meals for times when the patient is comfortable and well rested. We can make meal times as pleasant as possible, offer foods they like, and it sounds ridiculous, but their preferred foods. Dietary supplements as needed, daily weights, and record dietary intake. 1 second. Okay, so we're going to talk about Parkinson's. So Parkinson's is a slow, progressive, neurologic movement disorder associated with decreased levels of dopamine. The manifestations are the cardinal signs are tremor, rigidity, bradykinesia, so that kind of slow movement, postural instability. They can have some autonomic symptoms, so sweating, drooling, flushing, orthostatic hypotension, gastric and urinary retention, may eventually have some dysphagia, can also have psychiatric changes in a certain percentage of patients with depression, anxiety, dementia, delirium, and even potentially hallucinations, so be aware of that. Here's kind of the pathophysiology of Parkinson's disease. So you get destruction of the dopaminergic neural cells in the striata nigra in the basal ganglia, and this leads to depletion of dopamine stores. You get degeneration of the dopaminergic nigrostriatal pathways and the imbalance of excitatory acetylcholine and inhibiting dopamine neuroreceptors in the corpus striatum, and then you get impaired extrapyramidal tracts controlling complex body movements, and this all leads to the tremor, rigidity, bradykinesia, and postural changes. So the medical management treatment is directed towards controlling symptoms. Initial treatment is typically with anti-Parkinson medication, levodopa, followed by dopamine agonist when levodopa becomes less effective. So you can do levodopa, dopamine agonist, glutamate antagonist, anticholinergics, potentially cogentin. They may eventually be on a COMT inhibitors. So that's the catechol-methyltransferase, right? So that is a used along with levodopa therapy. COMT inhibitors can extend the effectiveness of carbidopa-levodopa therapy and allow for lower doses of the carbidopa-levodopa to be used. The stereotactic surgery is considered for Parkinson's disease who have motor fluctuations and dyskinesia that cannot be adequately managed with pharmacological interventions. The principal surgical option is deep brain stimulation, which has largely replaced the neuroblading lesion surgeries. And here they have the thalamotomectomy. This destroys the part of the thalamus to block the things that can cause tremors from reaching muscles. It's only used to control tremors, so it's not usually recommended for treatment of Parkinson's disease, but it is a potential surgery. And then they can do a pallidotomy. Hate these words. This is a surgical operation performed on the globus pallidus to destroy it, and the purpose of this operation is to relieve involuntary movements or muscle rigidity in select Parkinson's patients. And we have ongoing research for Parkinson's therapy. Michael J. Fox's foundation is doing some good stuff. So interesting to see what's coming in the future. So for our assessment of patients with Parkinson's, we want to focus on the degree of disability and function of the patient, including their ADLs, how independent are they with their ADLs, how is their cognitive function, what medications are they on, how is the response to medications, the emotional response and the individual coping, how are the family processes and how is the family coping, home care and educational needs, falls risk assessment in the hospital. This is huge. Remember, falls are considered a nursing quality indicator. So we need to be preventing these as much as possible. And then we need to assess the manifestation of potential complications related to this specific disorder. The goals could include improved functional ability, maintaining independence in ADLs, achieving adequate bowel and bladder elimination, attaining and maintaining acceptable nutrition, communicating effectively, and developing the positive coping skills. To improve mobility, we want a daily program of exercise, range of motion exercises if they're unable to do it much else. Postural exercises, so we're consulting with physical and occupational therapy, reinforcing the interventions they have, making sure that we have walking techniques for safety and balance, that they have frequent rest periods. When we're doing these, we want to avoid extreme fatigue. Want to make sure that they have proper footwear. Again, as a high falls risk, we want to make sure that we're not adding to that. You know, if they were a big heel wearer, that's probably out of the question now. And then use of assistive devices. Do they have a walker? Have they been trained on how to use the walker? Is it a crutch walker? Where are we at? So reinforcing those sort of things. So enhancing self-care ability. So we want to encourage, educate, and support independence. What modifications can we do so that they can be as independent as possible? If you're in the hospital setting, there's a lot of stuff we have that we may be unaware of. There's, it sounds terrible, but there's cups, handled cups with lids, so like a sippy cup. So if you have a hand tremor and you really want to drink coffee, those can really help a lot. You can get your utensils built up. If you're having trouble with coordination, they have little things you can snap on the plate so that you can push your fork to it, your fork to it, and keep your food on there, so you can eat by yourself. So that's kind of how to use their adaptive devices. And again, this would be a consultation with occupational therapy on things they may need to help them put their button their shirt, right? Just the little things we don't think about. If you don't have that coordination, how hard that could be. So occupational therapy can be great. Consult with them, reinforce their teaching, set achievable, realistic goals, encourage socialization, recreation, and independence. We want to keep them as involved as possible. Try not to, so that they're not isolated. Plan programs of activities. So there's several different activities out there that they can do. Support groups and referral to supportive services, counsel, social workers, and home health care. They may need to have a home study done to see how they can help there. So, and support groups are great for the patient and family. So Huntington's disease, this is a chronic progressive hereditary disease that results in choreiform movement and dementia. This is was also known as Huntington's chorea. There's a general lack of coordination and an unsteady gait often follow. As the disease advances, they get uncoordinated jerking body movements, become more apparent. Uh, Physical abilities gradually worsen until coordinated movements become difficult and the person is unable to walk. Mental ability generally declines into dementia. There is currently no cause for no cure for Huntington's disease, and no way to slow or stop the brain changes it causes. So treatment focuses on management of symptoms. So that could be managing the jerking movements, putting them on falls precaution, maybe aspiration precautions as they move up. They have this uncoordinated swallow, so eating can be difficult. One interesting intervention you can do for patients with Huntington's who have difficulty swallowing is providing deep, gentle pressure to the face as they swallow, and that can help coordinate those movements. And help patients with Huntington's swallow and eat. But it's eventually, it's just a progressive disease that we can do little about, which is unfortunate. To briefly touch on Alzheimer's disease, we'll cover this more in our psych portion. But it is called senile dementia, often called senile dementia. It is the most common cause of dementia. It's a chronic progressive degenerative brain disorder that affects about 4.5 million people in the United States. Research suggests that the oxidative stress plays a role in the pathology of this disease, so take that for what it's worth. People with Alzheimer's in the early stages memory loss may be mild. By the later stages of Alzheimer's, individuals lose the ability to carry on conversation and respond to their environment. Current Alzheimer's medications can help for a time with memory symptoms and other cognitive changes. There are two main types of drugs are currently used to treat the cognitive symptoms. So cholinesterase inhibitors. These drugs work by boosting the cell-to-cell communication and preserving the chemical messenger that is dependent in the brain of Alzheimer's patients. Its improvement is modest with this. Cholinesterase inhibitors may also improve neuropsychotic symptoms such as aggression and depression. So Alzheimer's patients can get pretty aggressive, so this may be helpful. It's commonly prescribed. Cholinesterase inhibitors include Aricept and Razidine and Exanol. The main side effects of these drugs are diarrhea, nausea, loss of appetite, and sleep disturbances. Some people with cardiac conditions, serious side effects may include a cardiac arrhythmia, so monitor for that. There is a medication called Namenda. This drug works in other areas in another brain cell communication network and slows the progression of symptoms with in patients with severe Alzheimer's disease. It's sometimes used in combination with the cholinesterase inhibitor, and it has relatively rare side effects, which include dizziness and confusion. All right, ALS. So this is amyotrophic lateral sclerosis, or Lou Gehrig's disease. This is a loss of motor neurons in the anterior horn of the spinal cord and a loss of motor nuclei in the lower brainstem. So the manifestations are progressive weakness, and atrophy of the muscles, muscle cramps, twitching, loss of coordination, spasticity, deep tendon, reflex, maybe brisk and overactive in spasticity, and difficulty speaking and swallowing. So this is progressive and uncurable. People with ALS can still think and learn. They have all their senses of sight, smell, hearing, taste, and touch. Yet the disease may affect their memory and decision making. ALS is incurable. Patients with this diagnosis should be supported and potentially encouraged to make an advance directive so that their wishes of how they want this treated moving forward can be done, right? Because we can support them with mechanical ventilation, all this, but they're not going to get better. All right, so just a few odds and ends here. We'll talk a little bit about degenerative disc disease. So this is low back pain is a significant public health disorder and has significant economic and social costs. There's a lot of missed worker productivity, a lot of missed social activity due to low back pain. Most back problems are related to disc disease. Degenerative changes occur with age or are the result of previous trauma. So as we get older, our discs may dehydrate and start to shrink. This is the cushion between the vertebrae and our nerve cell roots that come off of those. So if they shrink enough, you can get nerve impingement, which can produce pain along that nerve track, pain, numbness, paresthesia. So you can get the pain is called a radiculopathy because it radiates from the impinged nerve root. Continued pressure may produce degenerative changes in the nerves with resultant changes in sensation and motor response. Treatment for most of this is usually conservative. Rest fluids, anti-inflammatory medications, ibuprofen, something like that. Surgery may be required. For these back surgeries, they could do discectomies, laminectomies. So there's different surgical things we could do. Back surgeries are always iffy, in my opinion. And we need to monitor for complications after those. So we're going to talk about one type of spinal surgery. We will. I'm going to talk briefly about the assessment of cervical discectomy. So these are doing a discectomy in the cervical spine. So this is we want to determine the onset and location and radiation of the pain. We want to assess for any paresthesia, limited movement, and diminished function of the neck, shoulders, and upper extremities, because this is the discectomy, right? So think of where it is. It's the same thing, just different location. Determine whether the symptoms are bilateral or unilateral, right? These symptoms are usually unilateral, but cervical spine palpation to assess for muscle tone and tenderness. So how do we look around here? Range of motion in the neck and shoulders is evaluated, and any health issues and patient education is addressed. Diagnosis for these could be post-op, could be pain, impaired mobility related to the post-operative surgical regime. So they may be off with a discectomy. They're usually in a collar for quite some time. And then deficient knowledge about post-operative course and home care. So we'll need to educate the patient on their activity level, how there any assistive devices they have. They have a collar. How often do they have wear it? Can they take it off to shower? How do they clean around it? Um, Signs and symptoms to report, their follow-up visits, any medications they're taking, all that standard stuff. So potential problems and complications with these spinal cord surgeries can be a hematoma at the surgical site. This can result in cord compression and neurologic deficit distal to that. So we want to be monitor carefully for those and report them to the provider. They may have recurrent or persistent pain after surgery. Um, the goal of surgery is to, improve movement and decrease pain, but you can have recurrent or persistent pain after surgery. It should be reported to the physician and treated depending on the cause. So the goal may include relief of pain, improved mobility, increased knowledge of self-care ability, which is important, prevention of complications, always good. Um, they may need to we will need to, nursing intervention immediately post-op is, of course, their assessments. We want to relieve the pain, improve mobility, monitor and manage potential complications, and provide home and community based health. So what are they going to, what kind of sort of help do they have at home, sort of thing. And that, as long as it was, is it.